we have the ability to treat three birds with one stone: cataract, spectacle dependent, and glaucoma with all the MIGS procedures that we have. In the MIGS world, let's focus on that. Is there something that you're really excited about? Kind of where is the trends going there?
So I think the whole world of glaucoma is sort of kind of merging. It's like intersecting with refractive surgery, and I feel like it's an opportunity. I
Hmm.
feel like so kind of going back to refractive surgery. If you were to put in a non-toric lens in someone who needed astigmatism correction, you'd really be leaving something on the table. And I feel like the same is true for glaucoma patients. We often have patients who are there for their cataracts, so not because their glaucoma is uncontrolled, but we will do a mixed procedure. So things like an eye stent, like a hydrus, things like a goniotomy, a GAT, angle-based procedures that don't necessarily add a ton of time or risk to the procedure, but are able to stabilize that glaucoma, and sometimes get patients off of their drops or reduce their drop load, so that in future, you know, if they were to need that filtering surgery, their conjunctiva is in a better spot. We're not worrying about compliance, about side effects, things like that, and patients really love that. I feel like it's kind of interventional glaucoma has really just been the key to everything that we do. Obviously, our practice is a little bit skewed, and we wear kind of many hats. But starting with that, but even starting with lasers. We do a lot of lasers instead of having patients on drops. But MIGS combined with surgery, combined with refractive cataract surgery. So we all know that glaucoma reduces contrast, and so traditionally, I would agree most glaucoma patients probably wouldn't be well suited to a full range of vision like a PanOptix, a Synergy, an Odyssey, an Envy. But things like extended range lenses, so those non-diffractive options we have nowadays, we actually have the Pure C lens here in Canada. We've had great successes with it so far, and we haven't had it that long yet, but we're doing really well. The Vivity, of course, has been a heavy hitter in our practice for quite a while, and we'll combine that with those mixed procedures. Now, it's not appropriate for everyone. It doesn't go in every single eye. If someone has, a completely black field and a cupped out nerve, well, that's not really appropriate. But those patients that are, a little bit older perhaps, and things are really nice and stable. We have the benefit that we've monitored them for years. They do fantastic. You can stabilize things and give them that range of vision. So I think gone are the days where glaucoma kind of ruled out any refractive options. How do you guys kind of deal with that?
And Becky, what about you?
Yeah, I would say much the same. We don't want to leave options on the table for patients if we have the opportunity to address elevated IOP at the time of surgery or even its control with an eye drop. We just see so much ocular disease. I mean, I feel like 100% of the glaucoma patients I see, I was on the phone with a friend 2 days ago and she's like, my dry eye practice is thriving. So, what are you doing? She said, well, I just went to the glaucoma practice in town. And the glaucoma doctors they just can't deal with dry eye. I don't know if you would agree. There's just so much ocular surface disease when it comes to glaucoma drops. And it's a challenge. So, if we can do a combined procedure, the benefit and the value for that patient is enormous in the short term and the long term. One of the comments was just about ocular surface and how the cornea changes with age. We can anticipate those things. So, being able to have that opportunity, I think, is key. In thinking about connecting with patients, we kind of hit on this a little bit earlier. Giving the patients the options, helping the patients understand expectations. One of the things that I've always challenged other surgeons to do, and one thing that I've always done in my practices is whenever we do continuing education courses or education for ODs specifically, we talk about outcomes. We put them out there. We like to be transparent with outcomes. And it helps referring doctors understand, hey, you can trust us. We hold ourselves accountable. So I'll have slides on almost every type of implant we've done over the past year so that we can look at those. But it's important, I think, internally too, for me as the OD and my surgeon who might not be seeing all the post-op care to understand what are the outcomes. Are we going more myopic, more hyperopic? How much is a spherical equivalent with this certain implant? So we can pivot. That question about would I put a trifocal in this or a light adjustable, it's interesting to think about. And when you look at the outcomes, it helps make data-based decisions instead of, we were on a call a night ago and we were all talking about, just some of these really complicated patients who are just frustrated and upset with whatever it is. And it's easy to make emotional decisions like, oh, I don't want to work with this technology for whatever reason. Make data driven decisions. And so I would say in our practice specifically, we love to combine procedures. We love to give the data on IOP reduction and then the data on what our spherical equivalents are with these technologies and the range of uncorrected vision that we're seeing. And I've noticed referring doctors like that data. A lot of doctors are data driven.
I think it's really interesting to also note that it's not just like, I think ocular surface gets the bulk of things with good reason. I mean, glaucoma drops are horrendous for the surface of the eye. I often say to my colleagues, I'm sorry, in our practice, we create a lot of these problems, but hey, you have some, ongoing business. So, the ocular surface is a thing, but I mean, a controlled pressure of 15 on 3 meds is very different than a pressure of 15 with a drug eluting implant. So something like a Durista or an iDose, which I know you guys have. We don't have it approved, but we have used it, with good success, or with a MIGS, which of course gained its fame right here with the boss here in Toronto. So, those procedures, that pressure, a pressure of just one number, we think about that, and that of course doesn't tell the full story. We have the diurnal variations and things, but it's that fluctuation and those, few missed drops, or people are human, they're going to forget their drops, even if we're the most compliant patients ever. Things happen, back orders happen. We're currently fighting some of that with our preservative free drops here. And so I just think there's benefits beyond just the ocular surface with those glaucoma procedures.
Yeah, I think that one thing that's interesting, it's not so easy. So like sometimes you'll see a cataract eval, they got a good looking cataract, and then you look at the nerve and you're like, they might have glaucoma. And then if we go back to the beginning, we're like, okay, we want to correct the vision. And then the question is like, well, do we correct the glaucoma at the same time? Or like, do we just correct the vision and then we'll come back afterwards and see, do they have glaucoma? And like, are we gonna be able to get an OCT and like a visual field through that? That's one thing that I saw in my residency. I did that at Eye Center of Texas in Houston. And it was like, I felt like 50% of our cataract evals that we were getting had some kind of glaucoma component tied to them. And so then I think that me just being how nerdy I am and doing a deep dive on like these patients come in and like they want their vision corrected too. And so the question is like, well, how do you do that? I mean, we have a patient who was referred in last week for SLT. And when I was doing gonio, I'm like, they had PAS, they had a narrow angle. I'm like, okay, actually, this is a chronic angle closure patient, not open angle. And so we talked about they had some cataracts, we're taking out their cataract. And it's really interesting on these patients. It's like, okay, well, I want to correct my vision too. And I want to have the best chance at correcting my distance and near vision. And I want to minimize the chance of wearing my glasses. And they had like 0.75 SIL against the rule. And it's actually one of the questions that just came in, Nick. So it's like you could use, I mean, let's say the patient doesn't have glaucoma, even they do have glaucoma, and we're going to do, hopefully cataract surgery, and then the angle will open up enough to do MIGS. But like Nick, in that patient, I mean, are you doing LAL all day long, or are you doing one of these enhanced monofocals or an extended depth of focus and blending them? Or are you like, they've never had a history of blended vision or monovision? Like, how do you approach that?
Well, I mean, the LAL is huge for our practice. I would definitely do that all day. And if cost were neutral, and I tell patients all the time, if the cost weren't a part of this or the costs were the same, we would do LAL because you take away the variability of the healing process and you can treat and customize. And if you want to try, I get that question all the time, right? I had monovision in my contacts. I hated it, couldn't stand it. Well, the lens, although it's not a depth of focus lens, it's a little bit aspheric. So it does have a little bit of optical overlap. And so you can get away with just a touch of an offset where it's very comfortable. You don't have the anisometropia problems. You don't have the depth perception problems. And if you end up being really sensitive to that, you can undo it. So I mean, the LAL would be the way that I would go in those cases. But I mean, combining it with glaucoma procedures is super, super easy. And the beauty of the LAL now, patients are always a little hesitant up front because of the time that it takes, but that's not a bad thing because it's the test drive time and they quickly realize that, actually having the time is nice. For me, if I'm managing glaucoma, it also gives me a chance to really capture data on their pressures. And if they've got more severe glaucoma and pressure where we need to have it low, we need to have it stable, and we're really looking at diurnal variations, it's nice to see that patient once a week because it's kind of built into that. So I definitely do not hesitate with LAL for glaucoma patients.
So
Nick,
Nick,
I
you
used to think
mentioned
that the
diurnal.
correct. Oh,
Sorry.
go ahead, Neil.
I was going to say, you mentioned the diurnal pressure. So one of the things we've actually used in our practice for kind of a number of different things, but we've kind of done studies pre and post surgery and kind of a number of different things, but we've used an eye care home tonometer. So, our technicians use them. And so patients are familiar with the device. We train them how to use it. So some of our kind of applications for that would be a glaucoma patient, for example, with, a pressure of 10. Every time they come in the office, a pressure of 10, but they're progressing, their fields are getting worse. This is something we've had, really good success with. You mentioned bringing patients back into the practice. Would that be something that might be useful in your practice?
It would, for sure it would. We don't have that here. I mean, but our, with the LAL, they're just kind of it's part of the process. They're coming back in. So if it is something that if I can take advantage of them coming in several times, I try to stagger their visits. Now, usually with the LAL, there's appeal to having them coming in at the same time, just if there's cornea instability. But if it's a perfect cornea, we're not really worried about that. It's not an RK patient or something like that. I'll bring them in at different times throughout the day to get an idea of where their pressure is, if I'm concerned about it. And that's an advantage. I mean, that's a strategy. Um, Plus, we have the ability to do, serial fields. Like we use the Radius quite a bit, the headset, which is a quicker one. I mean, it's a quicker field. It's definitely easier, more comfortable for patients to do. So a lot of times we'll just run a real quick. It takes 2 or 3 minutes.
It's so much more ergonomic for patients. Like I find patients with like scoliosis or like neck issues, they can just sit more comfortably. We've had a good response from that.
Yeah, and we do that all the time. I mean, sometimes if they're here for an adjustment visit, they're they're partially dilated. So there is that in those instances, but we'll do it quick, right? When I put the drops in, just to get an idea if we haven't had one in a while. Or if there's something that I'm really concerned about, we'll just kind of add it on to that visit. And it does not take that long. You don't have to take the patient to a different room. You can do it right there in the exam chair, and it's great. How do you guys manage? I mean, Bobby, do you manage glaucoma quite a bit? Or what happens? I guess a tricky question is somebody's referred to you and it's clear that they have glaucoma, but maybe they weren't told before. That's a sticky situation.
I mean, it's always like, I mean, if you find something that wasn't referred to you, usually I just blame it on a test. Yeah, we do this one scan that I bring all the way over here. And this one scan, looking at the note, I'm looking at it and yeah, it looks like this. So I'm gonna call your doctor. We're gonna go over it. But right now it looks like that. So there is a high likelihood that we're going to just go ahead and lower the pressure at the same time, just because we have this one additional scan that gave us this one additional finding. So we're going to just go ahead and do this one additional treatment. That's generally how I go about doing it. But yeah, I feel like if they have glaucoma, for me, it's like a no-brainer. I mean, I think it was like in 2017, we presented the iStent inject data at American Academy of Ophthalmology, and like somewhere between 84 and 88% of those patients were medication free at 24 months. And it was like that was like my first like aha moment. Like, wow, okay. Like, man, if I didn't have to brush my teeth twice a day, or, if I didn't have to put eye drops in twice a day, I would sign up for whatever surgery, eye surgery or teeth surgery that I'm just like not having one less thing in my life.
Yeah, I mean, eye doctors and dentists are always like butting heads, right? We got one on them for sure. That's a great point. I mean, the iStent is great. That's what we use most often, especially in our more moderate to mild cases. It does give you bang for the buck, and again, I can't speak as a surgeon. I've never done it, but it is fairly straightforward. Anu, what do you think within the glaucoma world? I mean, what do your surgeons say about iStent versus other procedures from the technical side?
Yeah, so I mean, an iStent's an easy add-on. We have other things that we can use as kind of standalones and that sort of thing. But I mean, we've had great success with iStents. I think one of the biggest myths was actually one that you just said, which is where you think about it logically that only in mild disease. But actually, we have used this in kind of more advanced patients where you just got to get the lens out of their lenses. The problem, it's taken up too much space, and kind of you got to look at the underlying mechanism. Bobby hit the nail there, where there's so many patients that come and they haven't even been gonioed, so they're being mismanaged for God knows how long, and so that's kind of a key. We do use iStents. We also use Hydrus. I don't know how many of you guys. It may be a little bit less common, but we also have kind of Ike, of course, coined the term MIGS, all those years ago, but we're now using the term MIBS for microinvasive bleb surgery. So we have things like Saenz, which I know you guys have, and we have the PreserFlow, which hopefully will be over there soon. And so I think gone are the days where you just kind of have to jump to a trab. It's heartbreaking when you saw those 45-year-old patient with a trab for mild disease, and it's just like, it's wild. Now you have these options. We talk about a stepwise approach, starting with MIGS. Starting with laser, actually, forget, jumping up with the drops as you need to, and then going to your MIGS, your MIBS, and then eventually if you need filtering surgery. So I think it's a really exciting time in both glaucoma and refractive surgery. It has a different focus, refractive surgery being kind of more of an elective type of thing, whereas, glaucoma is still medical, but there are all these premium options that are available. And I think that's a really exciting thing for patients. There are lots of patients out there like Bobby who would do anything to get off their drops. So
yeah. I know even like drug delivery, right? Like
Yeah.
in US, we have Durista, we have iDose. And I mean,
And
I
you can
think,
combine that with your MIGs, right? So
right, combining them or even considering it doing earlier, like, there are a lot of people who forget to put their eye drops in. They're
yeah,
accidental follow sleepers. Let me just put the kids to sleep or the grandkids to sleep. Boom, you're out for the whole night. Not
absolutely.
speaking from experience, but just throwing that out there.